Welcome to InstaLecture number 91, and in this edition of InstaLecture we'll be discussing and trying to simplify the concept. We try to simplify the concepts about CAH, congenital adrenal hyperplasia. And in this discussion, we would be firstly try to understand the three key ideas that you need to learn at the beginning about CAH. Secondly, we would explain why CAH, congenital adrenal hyperplasia, is called congenital adrenal hyperplasia. Thirdly, you try to simplify the sub-classification, the subtypes, and the clinical presentation. Why 21 hydroxylase deficiency is present with ambiguous genitalia. Why there is a salt wasting variant in 21 hydroxylase deficiency. How it is different from the other twos, that is 17 hydroxylase deficiency or the 11 hydroxylase deficiency, the major forms. All these key concepts and also the sub-classification, the classic versus non-classic variant of the 21 hydroxylase deficiency. All these key concepts we'll be learning in this session of the InstaLecture number 91. So at the beginning, there are three things you need to learn to understand CAH. Firstly, it's a inborn metabolic error. It's a enzyme deficiency disorder. And not a single enzyme deficiency disorder, but a multiple enzyme deficiency disorder. It could be one disorder, could be one enzyme deficient, the other one there will be other deficient in the respective subvariants. But the common feature, the common theme in the congenital adrenal hyperplasia is this, that all of them, typically, there is a defect in the biosynthesis of the cortisol. Because cortisol, along with sex steroids, along with melanocorticoid, is produced from the adrenal cortex. So this is a inherited, usually inherited via the autosomal recessive pathway defect. It's an enzyme deficiency disorder. It's an inborn metabolic error where there is a disruption in the steroidogenesis of the steroid hormone formation in the adrenal cortex. And they have some common features. All these diseases. This is not a single disease, but it's a heterogeneous group of disorder. That means depending on which enzyme is deficient, it could present in various ways. That would very simplify in a moment when we progress to discuss about the other slides. But the first thing that this is it's an inborn metabolic error. This is an enzyme deficiency disorder. And the second common characteristic of these diseases, this group of diseases, that they're all characterized by, typically they're usually characterized by the defect in the biosynthesis of the cortisol. And the third, as the cortisols are produced in a low or minimal amount, that would cause excessive secretion of the ACTH. And that's why the ACTH causes hyperplasia of the adrenal cortex. And that's why we call it congenital adrenal hyperplasia. So the common features in this is that they are all autosomal, they're typically autosomal recessive inherited group of diseases which are characterized by defect in the hormone biosynthesis in the adrenal cortex. And if one hormone cannot be synthesized, then the intermediates, they get channelized to produce other hormones. And then excess of other hormones are synthesized, either sex steroid or melanocorticoid. But the common thing is that cortisol synthesis is usually defective. So all of them, cortisol synthesis would be low. And the third feature, ACTH, as the cortisol is low, ACTH would be high. So these key concepts you need to understand at the very beginning about the congenital adrenal hyperplasia. So the next big concept about CAH is this, that if one hormone cannot be produced from the adrenal cortex, so obviously the intermediates would be then shunted towards producing other hormones. So at the expense of one hormone, it may be melanocorticoid, it may be the cortisol. Other hormones like sex steroid will be produced in excessive amount, and that can cause the presentation. That is the key idea of these diseases. So here in this disease, there is a deficiency of particularly the cortisol synthesizing enzymes. This is the very key feature in this disease. Low cortisol leads to production of the high ACTH. High ACTH causes hyperplasia of the adrenal cortex from the very beginning, because this is a autosomal recessive inherited disorder, inherited enzyme deficiency disorder, and that leads to bilateral hyperplasia of the adrenal gland. So that's why we call it congenital adrenal hyperplasia. That is the reason for calling it congenital adrenal hyperplasia, because it's happening as congenital because it's inherited and autosomal recessive. And secondly, the adrenal hyperplasia, the bilateral hyperplasia, is occurring because due to the presence of low cortisol that stimulates more amount of ACTH release from the pituitary, and that further stimulates the adrenal cortex to become hyperplastic, and often it weighs 10 to 15 times more than their usual weight. So these are basics which you can brush up to understand that why ACTH level is elevated, which leads to the development of the adrenal hyperplasia, because normally the adrenal cortex, this cortisol or glucocorticoid, if they're in sufficient amount, then they usually suppress the, or the excess amount, they will be suppressing the pituitary or the hypothalamus. But when the cortisol is low, there will be particularly high release of the ACTH from the anterior pituitary, and that ACTH will lead to the development of the hyperplasia of the adrenal cortex. So, as I already mentioned, that bilaterally adrenal glands could increase up to 10 to 15 times more than their normal weight. And another feature which can be seen, this is not unique for this, but can be seen due to the presence of high ACTH, that skin hyperpigmentation in CAH. And the idea concept is a different topic altogether, but I'm just explaining it brief, that usually the ACTH is synthesized from the pro-opio melanocortin, POMC. Along with that, it also synthesizes MSH, melanocyte stimulating hormone. So when a lot of ACTH is getting synthesized, also MSH, melanocyte stimulating hormone get good, the level could increase, and that obviously would cause hyperpigmentation in this. This is not unique for this condition, can be seen in other conditions like Addison disease. But you need to keep in mind this could be a presentation in the CAH, the skin hyperpigmentation. Now, mostly there are 4 deficiency, enzyme deficiency, because basically it's an enzyme deficiency disorder. And our focus would be initially would be to concentrate on the most common variant, that is the 21-hydroxylase deficiency, because it comprises more than 90%. And also to compare with the 2 other major variants, 11-hydroxylase and 17-hydroxylase. And for the sake of simplification, we're just mentioning as 21-hydroxylase or 21-alpha-hydroxylase. Another key concept that you need to keep in mind, in many countries, the newborn screening for this condition is usually done by the serum 17-hydroxyprogesterone level. So before we venture into understanding and comparing the subvariant 21-hydroxylase versus 11 versus 17, let us cover a few basic concepts. You know that adrenal gland sits on the top of the renal gland, that's what it's called suprarenal gland, and it has 2 portions which are embryologically different. One is cortex, another is medulla. And the outer cortex, they have 3 distinctive subzones. From the outside, they're called zona glomerulosa, zona fasciculata, zona reticulata. So you can remember by the name GFR, glomerulosa fasciculata reticulata. This is a simple mnemonic to keep it in mind. Now, each one of them, they're distinctive. The outermost portion, the zona glomerulosa, they usually produce mineralocorticoid like aldosterone. Then the fasciculata, they produces cortisol, glucocorticoid. And the reticularis, they usually produce androgen on the sex steroids. And CAH is essentially a problem in the steroidogenesis in the adrenal cortex. So let's start with the most common one, which you usually see in the CAH, because as I mentioned, it's a heterogeneous group. Depending on which enzyme is deficient, their presentation is different. But altogether, this group of diseases, we call it congenital adrenal hyperplasia, because ultimately all of them, they lead to cortisol, low cortisol, and increased ACTH, leading to the bilateral hyperplasia. So let's begin with the most important one, 21-hydroxylase deficiency. And as I mentioned earlier, this is the major subtype of the CAH, comprising more than 90% of all cases of CAH. And this is a basic idea to understand, which I already mentioned. Anterpituitary, they're releasing ACTH. ACTH usually causing this hyperplastic adrenal in this condition. That's why there's a bilateral hyperplasia occurring. Now, if you look at this image, you can see this 21, which is mentioned. A 21-hydroxylase is required for synthesis of both mineralocorticoid and the glucocorticoid. So when the 21-hydroxylase is not there, the mineralocorticoid like aldosterone, their level would be low. Glucocorticoid, their level would be low. And all the intermediates now would be shunted towards production of the sex steroid or androgen. So this is the key idea in the 21-hydroxylase deficiency, that you have this 21-hydroxylase enzyme is required to synthesize mineralocorticoid in the zona glomerulosa. It is also required to synthesize cortisol in the zona fasciculata, but it's not required to synthesize the sex steroid or androgen in the reticulus. So when 21-hydroxylase is deficient in the main subtype of the CH, obviously we'll be having low cortisol, low mineralocorticoid, and as all these intermediates now are channelizing to produce the sex steroid, there would be high sex steroid production. And if you understand this, then you can easily figure it out what is the clinical presentation, because they would be just like the low cortisol presentation, low mineralocorticoid presentation, and the high sex steroid presentation. And all this concept would be learning in a moment. If you want to look at the broader perspective, this one looks very daunting and challenging. So I have devised actually a simpler way to understand this, and I've discussed this about simplification of the concept of CH. Because if you wish, you can remember obviously everything, but I think there is a simpler way to understand the CH. And this one is a little bit simpler version, you can say. And here again, I'm focusing on this. The 21-hydroxylase is required to produce from the cholesterol, to produce aldosterone, and to produce the cortisol. So let me go to the whiteboard to simplify this concept. So basically, all the steroids which are synthesized in the adrenal cortex, they are synthesized from the cholesterol. And from the cholesterol in the zona glomerulosa, they would be synthesizing mineralocorticoid, M, like aldosterone. In the zona fasciculata, they would be synthesizing cortisol. And the innermost portion, C for cortisol, they would be producing the androgens, A for androgen. Basically, they are this sex steroid, SS, you can write this. So in this condition, what is happening, that 21-hydroxylase is required to produce mineralocorticoids from the cholesterol. It's also required to produce cortisol from the cholesterol, this 21. But it's not required in this step to produce the sex steroid. So obviously, when you don't have 21-hydroxylase, you cannot produce mineralocorticoid. If you don't have 21-hydroxylase, you cannot produce cortisol. So obviously, their level of mineralocorticoid would become very low in this condition. The level of cortisol would become very low. But as all the intermediates are now channelizing to produce sex steroids, androgens, so obviously the sex steroids level would become very high in this condition. And that's why you are getting ambiguous genitalia, precocious puberty, all this feature due to the high level of this thing. And also you're getting the feature of lack of aldosterone, lack of cortisol, like hypotension, nausea, vomiting, all this feature. This will be explaining in a moment, right? So let us go back to the PowerPoint again and focus on the presentation. I think it should be very simple right now to understand this. So this one I have again tried to simplify this, that basically this 21-hydroxylase deficiency, there are 3 hormones which are produced from the cholesterol in the adrenal cortex, mineralocorticoids, cortisol or glucocorticoid, and the sex steroids. And this is in zona glomerulosa, fasciculata, and reticulus. This 21-hydroxylase, which is the key enzyme missing in the 20-hydroxylase deficiency, the most common variant, they are required they are present in the zona glomerulosa, they are present in the fasciculata, and they are required to synthesize mineralocorticoid and cortisol. So mineralocorticoid and cortisol would be missing in this condition, but as those intermediate products, the metabolite in the synthesis, the steroidogenesis or the steroid hormone synthesis, they will be now channelized, moving, because these 2 pathways are blocked, so they will move to the other way. They will try to now prepare abundant amount of sex steroid. So that will be high sex steroid, but low cortisol and low mineralocorticoid. That is the key idea, the key concept in the 21-hydroxylase deficiency that you need to understand. So in 21-hydroxylase deficiency, the cortisol and aldosterone are decreased. And the steroidogenesis in adrenal cortex is now shunted to formation of a lot of androgen or sex steroid. This is the mother of all concept about 21-hydroxylase deficiency. So 21-hydroxylase deficiency, now another concept is that there are two subtypes. There is one is called classic, another non-classic. It's very simple. Classic means if there is a total or near total deficiency of the enzyme, roughly some to say 0 to 2% activity. And if there is a partial deficiency, like 20 to 50% is there, then you can say that is non-classic. So classic means total or near total absence of the enzyme activity, and non-classic means partial deficiency of the enzyme activity. And their presentation would vary also according to this. 21-hydroxylase deficiency, the classic form, some people also use the salt bursting form. What would be their presentation? You don't need to memorize this. You can figure it out on own, because I mentioned to you that this is a problem of lack of aldosterone, mineralocorticoid, lack of cortisol, and high of sex steroid. So what does aldosterone do? Aldosterone basically acts on the distal nephron. And in the distal nephron, what does they do? They usually basically, they capture the sodium, along with they also grab the water, they bring it back, and they usually dump the potassium. So when you don't have aldosterone, what would happen? The reverse thing would happen. So obviously you'd be losing more sodium, that is the salt. That's why salt losing. You'd be losing more water. And obviously your potassium cannot be dumped out, so potassium would accumulate inside. So there would be hyperkalemia. So you'd be having hyponatremia, hypovolemia, and hyperkalemia. And obviously due to the low cortisol, you can have hypoglycemia, hypotension, all these features could be there. So this would be the initial presentation. And in the females, as they have a lot of sex steroid, particularly androgens, that would causes clitoris enlargement. So their genitalia would become ambiguous. It's very difficult to figure it out that they are female in that case, looking at their genitalia. So that is, and in the males, due to this excess androgen, they can have precocious or early puberty. This is the feature of the classic variant. In some cases, they could be very severe, leading to shock also and death. And as I mentioned, features of excess androgen, because this is basically in this 21-hydroxylase deficiency, excess androgens are produced in the zona reticularis. So excess sex steroid hormones. So obviously in the female, they will be presenting with ambiguous genitalia because testosterone levels are elevated. There will be enlarged clitoris, and the males, there could be early puberty. This is a point you need to know. And the other features are low aldosterone and low cortisol. So 21-hydroxylase deficiency, basically, depending on the level of their deficiency, the story is same that you need to, if you know the deficiency feature of aldosterone, you know the deficiency feature of cortisol, and you know the excess presence, what could be happen due to the excess presence of the sex steroid androgen, you can figure it out the presentation on your own. Now there is a non-classic variant is there. Non-classic, as I already mentioned, that means partial deficiency is there. So the only thing is that immediately after the birth, there will be no urgent situation like that. They will be developing shock and something like this. So usually present to later in the life. And they can also feature with the presence of excess sex steroids. And also the key feature in this is that the presentation is not immediate usually at the birth, and not so severe like this. So sometimes they could be missed at the initial period to be diagnosed, because this condition is due to partial deficiency of the 21-hydroxylase. And the key problem later will be due to androgen excess only, that abnormal irregular menstrual periods could be there, that could be precocious puberty could be present. Now we move on to the next subvariant, the key subvariant, 11-hydroxylase deficiency. And I would focus on the key area that you need to understand how it is different from the 21-hydroxylase deficiency. And it's very simple to understand actually. So let us look at this thing. I would again go to the whiteboard and simplify this, but just look at this, the pathways. If you look at this 11 is required at the level of deoxycorticosterone to convert into corticosterone. And 11 is also required to produce 11-deoxycortisol to cortisol. So again, the story is quite like the 21-hydroxylase, that they are required at for the synthesis of the mineralocorticoid pathway, and they are also required for the synthesis of the cortisol pathway, but not in the sex steroid pathway. So in this condition, what happens that if the 11 is not there, if you look at the screen, then 11, if it is not missing, so deoxycorticosterone, DOC, they would start to accumulate. And here the deoxycortisol, 11-deoxycortisol will start to accumulate. The interesting part is this, that this intermediate in the cortisol they have no function like cortisol. They are not weak cortisol. They don't have the activity like cortisol. So obviously in this condition also, the cortisol is basically the defect. This is the cortisol function would not be there. But interestingly, this deoxycorticosterone, which is there, they have weak mineralocorticoid property. They are not as strong as aldosterone, which is a strong mineralocorticoid, but they still have weak mineralocorticoid property. So in this condition, they are, as they're accumulating in large amount, so the person could develop hypertension. Like, let me go to the whiteboard to explain this concept again in a simple way. So let me clear what we learned during the 21-hydroxylase, and let us focus again on this. So again, this would start with this, that this cholesterol, ultimately there is cholesterol here, and everything is synthesized from the cholesterol ultimately. And in the zona glomerulosa, they would be synthesizing mineralocorticoid. In the zona fasciculata, cortisol, and zona reticularis, we are synthesizing the androgens like sex steroid here. Now, interestingly here, that this 11-hydroxylase is required at a step where there is a deoxycorticosterone from that corticosterone, and ultimately there is a production of aldosterone here, which is the key mineralocorticoid. Now, and also this 11-hydroxylase is required to produce the cortisol also. Now, this interesting concept here is this focus, that this deoxycorticosterone which I have drawn, this has weak mineralocorticoid property. So now this we are not producing in this condition the aldosterone, but this deoxycorticosterone, their level is increasing. And this deoxycorticosterone, they have weak mineralocorticoid property, but if they're in abundant amount, they're increased in amount, they can cause hypertension. So you would be not having the feature of mineralocorticoid deficiency as you are seeing in the 21-hydroxylase deficiency, because here there is lots of intermediates are produced which have weak mineralocorticoid property. But there will be total deficiency of the cortisol, because the intermediate which is produced here, they don't have weak cortisol property, unlike the mineralocorticoid pathway. And obviously there will be increased synthesis of the sex steroid, because a lot of things will be channelized here. So in this condition is different. How it is different from the 21-hydroxylase is this, that the similarity is that both the cases there is a low cortisol functioning like 21-hydroxylase. But the difference is this, that in this condition, now we are not producing the ultimate mineralocorticoid, aldosterone, but we are producing some intermediates which still has weak mineralocorticoid property. So mineralocorticoid, if they're abundant in amount, we can still see hypertension, but we'll be not seeing any cortisol property here. That is the key difference of 11 versus 21-hydroxylase deficiency. So let us go back to the PowerPoint again and revisit these concepts which I understood. So again, as I mentioned, this 11 beta hydroxylase, if it is not there, 11 deoxycortisol would be accumulating. 11 deoxycortisol has no role like cortisol. So cortisol pathway is basically blocked in this condition. But in this condition, aldosterone production is not occurring due to this 11 beta is not converting deoxycorticosterone to corticosterone and ultimately to aldosterone. But still this deoxycorticosterone, which is not getting converted to corticosterone, still it has weak mineralocorticoid property. So definitely mineralocorticoid deficiency feature would not be unlike the 21-hydroxylase deficiency. And obviously there will be increased production of the sex steroid, because this has nothing to, because some intermediates would be converted there, and 11-hydroxylase is not involved in the sex steroid pathway actually. So 11-hydroxylase deficiency, in a summary, in a nutshell, this enzyme is required to convert deoxycorticosterone to corticosterone and finally to androsterone in the mineralocorticoid pathway. So deoxycorticosterone, DOC, accumulates. Deoxycorticosterone is a weak mineralocorticoid. So its accumulation would lead to the hypertension and mild hypokalemia, because they have the feature like mineralocorticoid. But aldosterone and renin are low because aldosterone is not produced here actually. So obviously the aldosterone and renin is low because there is a blockage even before the aldosterone production. Now 11-hydroxylase is also required to synthesize cortisol. And that pathway is totally blocked because the intermediates which are producing in that cortisol synthesis pathway, they have no role like cortisol. So features of low cortisol would be prominent here. But there will be feature of high mineralocorticoid in some cases because lots of weak mineralocorticoids are accumulating. And 11-hydroxylase deficiency also leads to inhibition in the cortisol production, which I already mentioned. But excess androgen would be again produced in this condition, like clitoral arrangement, because obviously some intermediates are now channelizing into that pathway because one of the pathways is completely blocked. So excess androgen is also produced in this condition, 11-hydroxylase deficiency causing clitoral arrangement in the females. This point would be common. Then what is the difference actually between 21-hydroxylase and 11-hydroxylase deficiency? That already I mentioned, but again I am repeating here. The key difference is increased mineralocorticoid activity in 11-hydroxylase deficiency. Though 11-hydroxylase is required in the mineralocorticoid pathway, but its blockage causes excessive accumulation of some weak mineralocorticoids like deoxycorticosterone, and they actually, basically these weak mineralocorticoids would still cause, if they're accumulated in excessive amount, they would cause hypertension. So hypertension would be present in 11-hydroxylase deficiency, but would be absent in 21-hydroxylase deficiency. That is the idea. Because 11-hydroxylase deficiency, there is not complete absence of mineralocorticoid, but is the accumulation of lots of weak mineralocorticoids. Now they are not producing aldosterone. This is the basic difference. Now we move to the third variant you need to understand, that is 17-hydroxylase deficiency. 17-hydroxylase deficiency. 17-hydroxylase deficiency, if you look at this chart, you'd be understanding this, that 17-hydroxylase is basically required to produce the cortisol and also to the sex steroid, but not in the mineralocorticoid. So ultimately 17-hydroxylase deficiency will be leading to decreased cortisol and androgens. So now cortisol production is blocked and the sex steroid production is the block, but not the mineralocorticoid production is not blocked. So in this condition, the androgen will be produced in less amount. So in the male, if you don't have androgen enough in amount, you can have ambiguous genitalia. This presentation features would be there. So decreased androgen level to ambiguous genitalia with undescended testes could be seen in this condition. So now we are reviewing the key concepts of in brief, the key concepts of the CAH. CAH, the common theme, it's an enzyme deficiency disorder. It's an enzyme deficiency disorder where there is some defect in the enzymes in the steroid hormone synthesis in the adrenal cortex. And all of them, there's typically, we usually see loss of cortisol synthesis. And some others were like in one condition, maybe there is a defect in the sex steroid synthesis or excess synthesis of the sex steroid. Another condition, there will be mineralocorticoid. But the common theme is that there is a low cortisol synthesis. And low cortisol synthesis would lead to the production of increased ACTH, which would again lead to the bilateral adrenal hyperplasia. And it's usually inherited as autosomal recessive. That's why they're called congenital adrenal hyperplasia. It comes in many forms, but there are three key variants. 21-hydroxylase deficiency, the most common one, 11-hydroxylase deficiency, and the 17-hydroxylase deficiency. The 21, usually there is blockage of cortisol production, blockage of mineralocorticoid production, aldosterone production, but excess of sex steroid. The 11 is blockage of cortisol production, but blockage of aldosterone production. But before aldosterone, there is some intermediate mineralocorticoid produced, deoxycorticosterone. Due to their abundance, there is no deficiency of mineralocorticoid as such over. But again, there will be increase in the sex steroid because some intermediates will be shunted to produce the sex steroid. And the last one, 17, it is required for the sex steroid synthesis and the cortisol synthesis. So again, there would be blockage in the production of the cortisol and the sex steroid, but there's no blockage as such in the mineralocorticoid. So if you understand this concept, I think you can easily differentiate the presentation but particularly you need to focus on the 21 hydroxylate deficiency. And the 21 hydroxylate deficiency, the classic versus non-classic, because that is the most common 90% cases. And why classic one is usually associated with salt wasting, because in classic one, there's almost complete deficiency of 21 hydroxylate, and 21 hydroxylate is required for the synthesis of both mineralocorticoid and the cortisol. So in 21 hydroxylate deficiency, you get ambiguous genitalia because no production of the cortisol, no production of the mineralocorticoid, all intermediates that shunting towards production of sex steroid. And this excess sex steroid, they can cause, in females, they can present with clitoris enlargement, realization, and ambiguous genitalia. In the males, they can cause precocious puberty. So this is the concept of the congenital adrenal hyperplasia in a nutshell. And I hope it is helpful for all of you. Thank you very much for attending this session.